I'm Susan Dubois. I'm an endocrinologist and I work for community care health centers, and I support this work. Mary and I have been working together for about 10 years now, working with the Texas Drive family. So I'm glad to be here today.
Metformin, why so popular? So metformin is often the first drug that doctors prescribe for patients with type 2 diabetes. Could you talk more about what metformin does particularly and why is it so common?
Metformin is one of the oldest oral agents that we have to treat diabetes. Metformin became on the market sometime in the 1990s. Metformin addresses insulin resistance and the amount of glucose that comes out of the liver. So we've talked in this series about the liver a lot, and one of the main functions of the liver is for glucose storage. So when we eat a meal, the glucose goes into the liver, and then when we're not eating or fasting, the sugar comes back out of the liver into the bloodstream. In people with diabetes, for reasons that we don't understand, they tend to sort of dump that sugar inappropriately out of the liver into the bloodstream. Some people will call it the leaky liver, but you wake up with a higher blood sugar than you went to bed with. And so metformin really tries to lower hepatic glucose production and stop that leaky liver. So it's a very good medication. To a lesser extent, it is an insulin sensitizer. That is, it helps our body use insulin more efficiently. We have many, many decades now of safety experience with metformin, and that's why it's one of our first go-to drugs. It's approved for use in prediabetes and diabetes prevention, as well as an adjunct, either a first-line therapy or in combination with other things in type 2 diabetes. It happens to be very inexpensive and widely available in many forms.
So in a sense, like you're using metformin to keep those sugar levels in that range that we want, so like from anywhere 80 to 100, kind of in that range, right?
Our target fasting range is as low as we can get it safely. In patients on insulin, we will often use that 80 to 130 range because people on insulin are at risk of hypoglycemia. If I have a patient who is not on insulin or a sulfonylurea and they're not at risk for low blood sugar, I'm perfectly happy for them to have a fasting sugar of 65 or 70, which is normal, but it's a little bit low for people who are at risk of low blood sugar.
Right. And so with metformin, what are some side effects to keep an eye out for?
So gastrointestinal side effects are by far the most common. And these can vary from a little bit of bloating or feeling like your abdomen is a little distended, to rumbly tummy, to diarrhea. And at the terrible end of the spectrum is even incontinence of stool. So patients may not want to leave their house because they're afraid they're going to have an accident. So that's a terrible consequence. But what they do in a very positive thing is they help us keep healthy bacteria in our gut. So our intestinal tract contains many billions of bacteria, and most of those are helpful. And when we have healthy bacteria inside our microbiome of our gut, we are healthier. We have less inflammation. And patients who take metformin seem to have a healthier gut biome than patients who don't.
And if a person is having side effects, how should they communicate this to their physician, to their provider?
Well, first of all, I would say anybody having side effects, if you're on a high dose of metformin, cut it in half. Anytime you adjust your medication on your own, it's a very good idea to go ahead and call the doctor's office, leave a message with the nurse that I've had to change my medicine. I want the doctor to know, because we don't necessarily always want to wait for that next appointment, especially if it's, longer than a few days or weeks away. If you have to discontinue the medication because you're having terrible, terrible side effects, certainly do that. And maybe they can prescribe an extended release preparation or a different formulation. There was a time when a lot of my patients who'd been tolerating metformin for a long time started getting diarrhea. It turns out that the pharmacy had purchased a new generic that just wasn't tolerated the way it was formulated. And so we actually said, could you please go back to the old manufacturer? So always letting somebody know is a good idea, especially if you've tolerated it for a long time. And other thing I'll say about that is anybody who's on metformin or another class of medications we call the GLP-1 agonists, those are things like Trulicity, Victoza, Ozempic, Celequa, and you have nausea, vomiting, or diarrhea, you should hold the medicine until that episode is over, because even though you tolerated the medicine really well before, once something happens and your tummy is upset, taking these medicines can prolong it. So I just say, just hold it for a few days. When you're back to normal, reintroduce it. And if the symptoms recur, then let your doctor know. During that time, though, if you're not feeling good and you've adjusted your meds, you have to follow your blood sugar more closely, because your routine is very different. When your routine is off, you need to check more closely. So on sick days, I'll usually say check at least 3 times a day and notify me if your blood sugars are running terribly high, certainly if they're going above 300.
So we talked a lot about the short-term effects of metformin. What are the long-term effects of metformin, if any?
I'm glad you asked that question, because so many patients read and hear things on the internet or from friends and family, and they say, I'm worried I've taken this metformin. Will bad things happen to me over time? And there's absolutely no evidence for that. And in fact, if we go back to that landmark United Kingdom prospective diabetes study that took place over 20 years with a 10-year follow-up afterwards, patients who were in the metformin group had a 33% lower risk of heart attack and a 27% lower risk of death. So following people for 30 years actually lowered their risk of dying and of cardiovascular event. I think that speaks to the safety of the drug. One of the reasons why people started asking these questions is there was an earlier form of the drug that was taken off the market called fenformin. And fenformin was associated with a dangerous acid buildup in the blood called lactic acidosis. But people did such a good job educating healthcare system about this risk with metformin that people did not use it in the wrong population. So you should not use it in somebody who's on dialysis or has stage 4 chronic kidney disease. For a while, we didn't even use it with earlier stages of chronic kidney disease, but we learned it was helpful. So over time, we know that metformin is one of the safest drugs we can use. But when you're in the hospital, because you have something going on, often we'll hold it. If you get a dye study, like a CT scan, we'll hold it. That doesn't mean it's dangerous. It just means we're taking appropriate precautions to keep our patients safe.